to
And I just realized I had to hit play on recording, so I think we're good now.
walk me through it. Okay, so now the template is up right now. I need to be able to. There, how's that?
Perfect.
All right, great. All right, so we can roll.
I'm going to mute myself.
And you'll, if any questions come up, you will keep track of them in the chat bar.
Yes, I'll watch them in the Q&A, and at the end, I'll go through those with you.
All right, that's fantastic. Thank you. Well, it's a real privilege to be here tonight, so thank you for inviting me. It's a privilege to speak to all the school nurses this evening. We really value and treasure the work that you do and respect the work that you do. So thank you for attending tonight. As Sarah mentioned, I'm an adult endocrinologist, but I also work with many teens and run Diabetes Training Camp Foundation that runs fitness and multi-sport camps for adults with type 1 diabetes. And we also have a teen boot camp for teen athletes and their parents, pretty unique camp. So I'm happy to answer any questions about that as well. What I wanted to do tonight was talk a little bit about optimizing insulin levels for activity, exercise, and sport, and try to take a little bit of a deeper dive and maybe help you all think about insulin and the action of insulin as it relates to activity. And although you may or may not be out in the field or on the courts with your students with type 1 diabetes, you're certainly with them on a daily basis, and I'm sure are well acquainted of the challenges of glucose management around activity and exercise, and certainly spontaneous activity and exercise. So with that in mind, I created some simple objectives. There's really no disclosures for this talk. We're not going to talk about brands or anything like that, but the simple objectives were to describe the most common glucose response to exercise and physical activity, that being low blood sugar or hypoglycemia, and then get a little bit into, I guess, scratching the surface, the review of insulin action and its role in mobilizing fuel for the working muscles. Of course, our working muscles utilize glucose as one of its main fuels. So we're going to look a little bit about that, review the impact of what I would call being over-insulinized and how that results in the risk for hypoglycemia or low blood sugar, and at times severe low blood sugar, and just identify some basic insulin management strategies to decrease the risk of hypoglycemia for exercise and sport and or just regular old physical activity. So this is some really simple data out of a DirectNet study group looking at the glucose response to exercise in a group of children and teens with type 1 diabetes. So I'm not sure what level you're all working with. I presume there's a lot of junior high and high school nurses here with us tonight, but this is really very much an observational study looking at what happens to the glucose levels when you put about 50 teenagers with type 1 diabetes on a treadmill in the late afternoon. And that time was chosen to kind of mimic the time of day where kids are generally more active or participating in sports or exercise. And there was really no other major interventions but to observe their glucose levels and monitor them for low blood sugars and treat them if they had a low. So it was a 75-minute protocol, and they hopped on a treadmill for moderate intensity work for 15 minutes, and then they take a break for 5 minutes and monitor their glucose levels and treat if they had a low. There was really no strategic interventions related to their insulin levels. So there was no pump adjustments or insulin dose changes or plan for carbohydrate supplementation during the exercise other than if they had a low blood sugar. What else can I tell you about it? It's I think on average the teens who did this study were exercising up, 3 to 4 plus hours after their lunchtime. So there's the curve. It's a curve in terms of glucose levels that's been reproduced over the course of time since insulin was discovered about 100 years ago, that the most common response to exercise with insulin being dosed in the setting of type 1 diabetes is that there's a decrease in the glucose levels as exercise proceeds, especially in the first 30 minutes. So you can see this graph that I don't want to get too caught up in the details, but there's over the course of 75 minutes, there's on average about a 50 to 75 milligram per deciliter decrease in glucose levels. So about a point per minute over the first 60 minutes of exercise or so. And of the 50 participants in this trial, only one had any kind of meaningful increase in glucose levels while on the treadmill. So 49 out of the 50 had a significant decrease in their glucose levels. And one of the interesting findings, I guess, from this, and I don't know why this wouldn't apply to adults either, unless in case you're interested in adults and type 1 diabetes, that their baseline glucose level, where they started with their glucose level prior to getting on the treadmill, really dictated their risk for having a low blood sugar. So that's the data that you see on the right-hand side of the graph. The baseline glucose level less than 120 or 120 to 180 and or over 180. And then to the right of that, it was the percentage of participants who had a low blood sugar. And at the time of the trial, they had chosen less than 60 as hypoglycemia. But since then, the powers that be, and rightly so, have decided that less than 70 is our alert value, and that's what we're going to try to keep people above. So I edited the data a little bit to include what percentage of the kids had a low blood sugar reaction to exercise, as defined by a glucose level less than 70. So you can see that for those participants in the trial who started with a glucose level less than 120, 100% of them had low blood sugar during the exercise. And even if they started with a glucose level between 120 and 180, which is what we would consider a very reasonable place to start exercise, almost half of them had hypoglycemia less than 70. And as you all know, is often commonly advocated for, well, let's get the glucose levels up so they don't have a low during exercise. If the glucose levels started at above 180, still over 25% of the participants had a low blood sugar, less than 70. So the take-home point isn't really to say, all right, well, let's jack the blood sugar up to 240 so they don't have a low blood sugar less than 70. I think the take-home point is that, well, maybe we can strategize a little bit differently and help protect against a low blood sugar by either manipulating insulin levels or carbohydrate consumption during exercise. So here's a little bit more summary data of that data in terms of the immediate effects of exercise. As I mentioned, only one of the subjects had any meaningful increase in glucose level, and 83% of the participants had a significant drop, meaning that their glucose level dropped at least 25%, and the average fall was about 40% from baseline. Over half had a glucose level less than 70, and 1/3 had a glucose level less than 60. And as I mentioned there before, the data shows that hypoglycemia rate varies directly with the baseline glucose when exercise was initiated. And then finally, just a reminder, because sometimes we like to talk about rules that very rarely work in type 1 diabetes, but we like to talk about rules anyway. And there's the old 15-15 rule. And you should keep in mind that 15 grams of carbohydrates was entirely insufficient to reliably treat hypoglycemia during exercise. So the kids who had hypoglycemia during the exercise on average required about 45 grams of carbohydrates to get their glucose level back up to a range that made it reasonable to proceed with activity again. Now, this is a little bit more complicated data, but I think this, and I don't want to get too into the details with it, but just using it to sort of follow up on that point of, well, how can we prevent hypoglycemia? What changes can we make to insulin or carbohydrate consumption to help protect these kids from low blood sugars during activity? And I'm going to maybe oversimplify this data, but I don't think you need to get into too much into the weeds here. What this graph is this graph shows you an intravenous glucose infusion rate. So this again is teens with type 1 diabetes, same time of day on a treadmill with basal insulin level, no insulin adjustments to pumps or injections. So they've got their background insulin levels going. They hop on a treadmill or they start exercising, and they have an IV in where the study coordinators could infuse glucose to keep the glucose levels normal during their exercise session. So as you can see on the left-hand side of the slide on the horizontal axis, it's about 4 o'clock in the afternoon to 45 to 60 minute exercise session. And then you see data across the slide out to 4 a.m. And my point in showing you this is just to hammer home the idea that the glucose infusion rate during exercise needed to increase threefold. You can see the rapid peak in the first 30 minutes of the exercise session here, that to keep the glucose levels normal, the investigators had to increase the glucose infusion rate threefold so that there was no low blood sugar during the exercise. So they've deemed this the early hypoglycemia risk period of exercise. In other words, the time period during the exercise, and a real significant increase in the glucose infusion. So this glucose needs to come from somewhere, and obviously we can't hook your school kids up to IVs so they can go out on the playground and not have a low blood sugar. But we need to think about, okay, this is a significant increase in glucose that the muscles are using. They had to infuse a lot through an IV just to keep them from having a low. So we need to think about, okay, the glucose needs to come from somewhere. Where is it going to come from? And then interestingly, which I think, everyone in the room, at least the Zoom room, is well aware of, there's also this delayed onset hypoglycemia risk period, oftentimes 1 to 3 o'clock in the morning, which will drive the kids' parents mad, I'm sure. But again, the glucose infusion rate needed to increase fairly significantly between midnight and 4 a.m. to help protect against the late or delayed onset hypoglycemia. So I just show this so you can imprint this picture on your mind as a reminder that if we're going to protect the kids from hypoglycemia, they're likely going to need glucose, and the glucose needs to come from somewhere. So it's either going to have to be generated in their body through normal physiologic mechanisms, or they're going to have to consume it to help protect against lows. It's not a failure to have to consume carbohydrates to protect against lows, because by definition, your kids with type 1 diabetes are generally over-insulinized for the activity that they're doing. So let's talk a little bit about insulin. Insulin's an anabolic hormone, right? It's a hormone that helps us store all of our substrates for use down the line. So a high level of insulin is designed to help us store our carbohydrates, store our fats, store our proteins for a time later on when we need to draw upon them. And those times are when we're not eating, when we're sleeping and our brain needs glucose, or when we're physically active. So, not a lot of people think about it this way, but insulin is it's a performance enhancing drug in a way. And our young athletes who have type 1 diabetes, who compete at a high level, actually need to get exemptions to be able to use insulin, because there's other people out there abusing it because of its anabolic activity. So during these times where the body needs to draw fuel for energy, where the body needs to make fuel for energy, these physical activity, fasting, sleep, our physiologically, our insulin levels, I'm talking about outside of diabetes now, for those of us who do not have diabetes, our insulin levels are steady and generally low. We generally have this very low background circulating level of insulin during these times that allow us to mobilize the stored fuels for brain function when we're asleep, or for muscular work when we're trying to engage in physical activity, sports, or even running around on the playground at recess time. So in normal physiology, again, outside of type 1 diabetes, as our bodies become active and our muscles set us in motion, insulin levels generally decrease to allow for fuel mobilization so that we can release our energy stores to meet the demands of the working muscle. And this applies to, you know, the young girl playing basketball, or the junior junior guy playing lacrosse, as much as it does to your grade school and junior high students who leave their desk and go out on the playground and start running around like mad for 30 minutes. It's just this immediate need for fuel. And in normal physiology, insulin levels decrease to allow for that. So this is a simple cartoon that I borrowed from my friend Michael Rydell, who's an exercise physiologist and expert in this field as well. It's a really simple cartoon showing what happens in normal physiology when the muscle on the right-hand side of the slide begins to do work and needs glucose to fuel the work that it's doing. And what happens at the level of the liver on the left-hand side of the slide to help accommodate for that need. So as the kids or high school students start to participate in physical activity or sport and their muscle starts working, for those who don't have diabetes, and for those of us who hopefully engage in exercise who don't have diabetes, as our muscles start to consume the glucose to propel us forward, the liver immediately starts making the same amount of glucose. So you can see with these arrows, glucose uptake increases in the muscle, and at the same exact moment, the liver, our glucose factory, is able to make the same exact amount of glucose to meet the amount of glucose being taken up by the muscle, and glucose levels just generally stay very steady, which is very maddening to our friends with type 1 diabetes, but that's just the way it is. And so for those who don't have diabetes, one of the major neurohormonal adaptations to exercise that allows for this to happen is that the pancreas begins to secrete less insulin and more glucagon, and the insulin to glucagon ratio coming from the pancreas, it changes, and that messenger goes right to the liver and tells our liver, hey, you need to make a little bit more glucose. The muscle is consuming glucose, and this all happens instantaneously. So a lot of interesting mechanisms at play, but that's one of the major initial hormonal changes that happens that allows for this. And I should say, to sort of set the stage for the challenge that our kids and teens with type 1 diabetes are up against, is that the way that this is all supposed to work, the system and the series that this is supposed to happen, is that the pancreas is talking right to the liver internally. So the pancreas is secreting insulin or changing insulin secretion and secreting glucagon and changing glucagon secretion. And immediately when it's secreted, it gets delivered right into the bloodstream and right to the liver. So that, in fact, as you know or may remember from past learnings, that when insulin hits the liver, over half of that insulin is cleared immediately. So half of the insulin that the pancreas secretes right to the liver gets cleared by the liver, does its job, and then the rest goes out to the periphery. So I just want you to keep that in mind when we think about the challenge that these folks are up against, which is we are completely bypassing this normal circuitry. Our teens and young children with type 1 diabetes are injecting or pumping insulin into their periphery first. So the periphery bloodstream and muscles are seeing the insulin, and it completely bypasses the normal circuitry of the pancreas delivering the message right to the liver and controlling the amount of glucose output. So there it is. As the muscle begins to work, insulin levels go down, glucagon levels go up, and the liver gets the message, hey, I need to make more glucose. And in normal physiology, it's exceedingly rare to see low glucose, outside of exercise or even during exercise. So here's a couple of other examples, again, modified by from Mike Rydell's work. If for some reason the insulin levels don't decline, now you see in the middle here, you see a big arrow of glucose going into the muscle and a smaller arrow indicating less glucose coming out of the liver. Hypoglycemia will ensue within 20 to 30 minutes if the liver is not able to keep up with the demand of the working muscle. So, and this is the situation when insulin levels stay stable or increase during the exercise session. And this is the situation for most people who are injecting or pumping insulin, that paradoxically their insulin levels are staying the same or paradoxically maybe even increasing. The counter-regulatory hormones like catecholamines and stress hormones may have a role here too, but they decrease the ability. So this inability of insulin levels to go down prevents the liver from keeping up with the demand of glucose at the level of the working muscle. And this is in the essence, the crux of why hypoglycemia is so common during exercise and physical activity in type 1 diabetes. Now, on the bottom third of the slide here, you can see a different scenario. If insulin levels are similar or very low, and we can talk through how these things happen, but let's take the example of a teen on a pump who disconnects from their pump for physical activity. So if insulin levels get low, now less glucose is being taken up by the muscle. Still some is being taken up just because the contraction of muscle is able to bring glucose into the muscle cells independent of the action of insulin, but not as much glucose is getting into the muscle. And with the low insulin levels now, glucose is potentially pouring out of the liver, and you can also get exercise-induced hyperglycemia. So we're not diving too far into that tonight, but certainly we see both hyperglycemic responses to exercise and activity and hypoglycemic responses or low blood sugars, with the most common being hypoglycemia. And what everybody's striving for is what you see in the top third of the slide. How do you keep glucose levels normal during the physical activity or exercise? So as I mentioned to you, I just want you to think about this this construct that as the muscle is engaging in physical activity, whether it's on the playground, the ball field, the basketball court, whatever, as the muscle is engaging in physical activity, though the body is trying to draw glucose from its stored fuel so that it can fuel the work that it's doing. And if you have a peaking insulin on board, look at some of the activities here that the insulin stimulates in green, or with the stop sign, some of the activities, some of the physiologic mechanisms that the insulin prohibits from happening. So if insulin levels are high, lipolysis is inhibited. So the breakdown of fat is inhibited. Well, the body is trying to break down fat to get fuel, to make glucose. Glycogen breakdown. So glycogens are stored glucose, right? Glycogenolysis, or breakdown of glycogen, is prohibited if insulin levels are high. Gluconeogenesis, so the liver's ability to make glucose, is inhibited, or there's a big break on that action if insulin levels are high. So at the very time that the body is trying to mobilize fuel, high levels of insulin or insulin activity will actually prohibit the very things that the body needs to do to fuel the working muscle. This is, I'm sure, I suppose you'll get a copy of these slides or have access to these slides, but this is just that in more detail, how high insulin levels affect lipid metabolism, protein metabolism. But in essence, they're preventing their breakdown. It's preventing the breakdown, which during exercise or sport is exactly what the body wants to do. So with type 1 diabetes, the athlete or insert, whatever you want to in there, we believe everyone has an athlete in them, but the athlete, the exerciser, the kid on the playground is generally over insulinized for the level of physical activity that they're doing. And this over insulinization limits the ability to mobilize fuel stores. It limits the body's ability to generate glucose as a working substrate for the muscle. And it limits the body's ability to keep up with the glucose uptake that's occurring at the level of the muscle. But we do have some control over, and the athlete with type 1 diabetes absolutely has some control over their fuel metabolism. As I mentioned to you, the challenge that makes them all so extraordinary that they're up against is they're bypassing the normal circuitry, but there still is some control over the fuel metabolism. And we generally think about this in 3 different ways. So they can adjust or modify their insulin levels. They can consume carbohydrates, as we saw in that earlier slide. The glucose has to come from somewhere, so they can consume carbohydrates. Or they can do a combination of both of these approaches, adjust the insulin a little bit and consume carbohydrates. And that's where most people end up falling. So you're all familiar with the insulin regimens of those with type 1 diabetes. We call them basal bolus insulin regimens to maintain normal glucose levels. And you can achieve this through multiple daily injections of insulin or insulin pump therapy, right? So this slide is just, it shows you a very simple schematic of what we're trying to do with basal insulin and bolus insulin. So we generally have either long-acting insulins or extra long acting insulins that serve as our basal insulin, or the infusion of a continuous infusion of a rapid-acting insulin 24/7 that provides this low-level background insulin to sustain our metabolic needs during rest, sleep, physical activity, et cetera. And then when we eat meals, as you know, with type 1 diabetes, we need a rapid peak in insulin to help store these fuels so that we can, again, draw on them at a later time, like when we want to be active or engaged in sports. So you can do this, as you know, through multiple daily injections or insulin pump therapy. And without getting into all the weeds of what's out there, we have a lot of options for basal insulin now. We have a couple of ultra long acting insulins, which are definitively once daily basal insulins. We have long acting insulins, which came around in about 2000. We have intermediate acting insulins, and even old school insulins like NPH. And then you can also mimic basal insulin needs by putting a short or rapid acting insulin into a pump and infusing it 24/7. So, and there's a lot of conversation and details that goes into pump therapy and versus multiple daily injections beyond the scope of this talk. But obviously, we can try to replicate normal physiology as much as possible, either with pump therapy or multiple daily injections. And now, thankfully, we have sensor augmented pumps and even some automated pump systems, which I'm hoping that you're seeing and the amazing value of them. If we're going to optimize insulin levels for physical activity or exercise, the crux of the matter is, in my opinion, we have to limit the peaking insulin levels. So I showed you what happens, how peaking insulin levels or high insulin levels puts the brake on all of the processes that our body needs to do to help fuel the working muscle. So As I see it, it's easier said than done for sure, but we need to limit the amount of peaking insulin levels circulating around and try to optimize the background or basal insulin levels. The background basal insulin will definitely provide a smoother ride in terms of glucose response to exercise. And the rapid acting boluses and peaking insulins just create much more instability and flux. And I hope to show you a little bit of that here with this simple cartoon where I could not stay within the lines with my coloring. So I apologize for that. But I just want to remind you, this is a graph of the insulin levels for rapid acting insulin. So whatever the teens or kids are on, if it's Humalog, Novolog, Apidra, even there's some newer ones, Fiaspen, Lumjev. In essence, the curves generally look like this, with maybe some difference with some of the faster acting insulins. But the point here is not to get too caught up in those details. It's just to show the peaking insulin levels following a bolus of insulin. So like a meal bolus or a snack bolus, what happens to the insulin levels and the time action profile of that insulin. And more importantly, to look at what one might anticipate in terms of the glucose response to exercise or activity during these different windows of when the peaking insulin is acting. So I've broken those down into simplistically into red, yellow, and green. And red doesn't mean you can't exercise or be active here, and green doesn't mean this is the only time you can do it. It's just to sort of differentiate higher risk periods for low blood sugar versus lower risk periods. So in the first couple of hours, as you see that insulin level peaking, if somebody is active or exercising during that peaking insulin time, so let's say the idea is, oh, I got to take a snack or I got to have a meal before I go out and play a sport. So I'm going to eat an hour to an hour and a half before I go out on the field, and I'm going to bolus for it. This is what's happening with their insulin levels. And this is what you can anticipate will happen with their glucose levels. Now, the glucose levels aren't graphed out here, but the rate of change for glucose levels during activity during that time period, the glucose levels are going to fall 2 to 4 points per minute. That's fast. That's really fast. That's 120 points, well, anywhere between 60 and 120 points in 30 minutes. So not only is it a fast rate of drop, but it's pretty disconcerting to look at on a continuous glucose monitor, which hopefully most of your kids have, or to see these arrows pointing down. But anyway, that's, as you know, if you engage in physical activity and have a peaking insulin on board in type 1 diabetes, that's where you're going to see these rapid changes in glucose levels. Now, if you're 3-4 hours plus out from the bolus, that's when you're going to get the greatest stability and maybe just changes of, hopefully 1 point per minute or so. And if you're somewhere in between, like 2 to 4 hours after the bolus, you're going to see still some pretty considerable rates of change with glucose levels, but maybe more in the range of 1 to 3 points per minute. So maybe in the range of 30 to 60 points over a half an hour rather than 60 to 120 points on the Dexcoms. Now, looking at the same data in terms of what one would need to ingest from the point of view in terms of carbohydrates to help protect or prevent a low. Again, these are rough estimates based on a lot of data and a lot of clinical experience. If one is exercising within 60 to 90 minutes of taking a rapid acting bolus in the setting of type 1 diabetes, they may require 30 to 90 grams of carbohydrate consumption per hour to help sustain the glucose levels. And if they're somewhere 2 to 4 hours out, they may need about 15 to 45 grams of carbs. And if they're 4 hours plus out from their bolus, that's when they're going to have the lowest carbohydrate needs. But they still may need 0 to 30 grams of carbs per hour to sustain the glucose levels. And what we're teaching our athletes to do is to use a fuel injector approach. We're not saying, take in 60 to 90 grams of carbs right now, right before you go on the field, or 30 to 40 grams of carbs at halftime. we're trying to teach people how to take a fuel injector approach and maybe take in 10, 15 grams of carbs every 10 to 15 minutes or every 20 minutes or every 30 minutes, depending on what their needs are going to be. But their needs are really going to be dictated by how much of a peaking and rapid acting insulin they have on board. And there's a lot of data to support this, and I don't want to get caught up in the weeds here, but this is data from almost 20 years ago where some outstanding clinician researchers looked at carbohydrate needs based on body weight 1, 2.5, 4, and 5 hours after a bolus. Now, the caveat to some of this data is this was a bolus of regular insulin, not a rapid-acting insulin. But I do want to show you that, look, even 5 hours, look at the bottom row there, even 5 hours after a bolus of regular insulin, these exercisers were still requiring 7 to 15 grams of carbohydrates to protect themselves against a low. And 1 to 2 hours after a bolus, they were on average requiring 30 to 60 grams of carbs per hour to help prevent a low blood sugar. So what about the idea that, well, you can prevent all this by reducing the meal dose prior to exercise and physical activity? You may be able to reduce the risk of low. What we see in the field is pretty similar to what they saw in the research lab, and I can try to show you that quickly here. This is what happens if somebody takes a meal and a bolus for the meal 90 minutes before working out at 70% of their maximal intensity. So about moderate physical activity. The red graph shows the glucose response to the meal and the full bolus. And then the green line shows the start of the exercise period. And the blue graph shows you what happens to the glucose levels if there was a 50 to 75% reduction in their meal bolus. So they cut the insulin dose at least in half. And the thing that I guess the main take home points from this slide is you can see that for those who don't make a reduction, so they got their full meal dose, the red graph is high risk for low blood sugar. So almost all of the exercisers in clinical research studies, and we see it in the field, who don't make a dose reduction and exercise at moderate to higher intensity within 90 minutes of doing it, have a high risk for low blood sugar. If you reduce the dose by 50 to 75%, you're just creating a cushion. So you're raising the peak of the glucose levels, and you can reduce the risk for low blood sugars. In the lab, in pretty well done experiments, 25% of people still have a low blood sugar when you make this kind of reduction. So that's not good enough, I don't think, and I don't think we should. I don't think we should accept that that's okay. That one in four of our athletes is going to have to come off the field, for a low because they bolus 90 minutes before they went out, even if they reduced the bolus. So you can see from this graph, you're creating a cushion. But I want you to look at the decline in the glucose levels following the start of exercise. So following that green line, you've created a cushion, but the rate of decline of the glucose levels, whether they've reduced their bolus or not, is really similar. So all you're doing is allowing somebody's glucose levels to get up higher. And then hopefully, 2 to 3 out of 4 times, they're not going to have a low. So you really, it's the bottom line is this is a really challenging and tricky time to be engaging in moderate to more intense physical activity. And we have to learn to teach our young athletes to move their meals and their boluses further out from their exercise session. The other thing about this peak and fall is now with these amazing devices and these amazing continuous glucose monitors that have revolutionized everything that we're doing. It's still very disconcerting. So even if you reduce your meal bolus by 50 to 75%, as shown on this graph, even when you do that, and even if you're protecting against a low, your CGM is still picking up on this decline, still showing 2 arrows down, and it's sending all kinds of signals to the brain that, oh man, I screwed up again. I'm going to have a low. And at the very time that we're trying to let our kids have fun on the playground or excel on a sports field, their mind is totally consumed by this idea of, oh my God, I screwed it up again. I'm going to have a low. What did I do wrong? The very things we do not want them thinking about when they're out there on the field. I'm not going to get into that. So it's really hard with the rapid acting insulins on board. And if I didn't want to drive home any other point to you all tonight, is it's, you know, the simplest maneuver, although hard to implement, I understand, to reduce the risk of hypoglycemia for our young athletes with type 1 diabetes is to get the bolus insulin and the peaking insulin out of the mix. And once we do that, then we can start looking at basal insulin considerations and what should we do with their basal insulin, their background insulins. If they're on multiple daily injections, they're injecting a basal insulin hopefully once a day, I guess maybe twice a day, but hopefully we can get them on insulins that they're injecting once a day. Or if they're on pump therapy, what can we do to help them with their pump adjustments to decrease their insulin levels? And as I showed you early on in the slides, what we're trying to do with basal insulin manipulation is we're trying to mimic the normal response, which is lower the background insulin just a little bit to try to help mobilize the fuels that our working muscles need for exercise. So I've outlined some simple things here, considerations related to basal insulin. If somebody's on multiple daily injections, it's quite honestly, it's really hard to manipulate the long-acting insulins too much. You may be able to adjust them by about 20% or so, I would say maybe 30% to try to lower the insulin levels. But oftentimes, you know, that protects them during the exercise, but then their background insulin levels are too low for other times of day. And the other thing that I would just say about this, you know, we don't have time to take a deep dive, is that one long-acting insulin is not the same as the next, is not the same as the next, especially in one individual. That our students and athletes with diabetes respond differently to the different long-acting insulins. And although insurance companies see them as interchangeable, they're not always interchangeable, and we have to keep that in mind. So, you know, I guess as a practical example, I would say to you that, and I'm just making up an insulin, I'm not advocating for it. Like if you take a common insulin like Lantus insulin or insulin glargine, if the teen is on it once a day in the morning and they're frequently active or exercising or playing sports at 4 o'clock in the afternoon, they may have an entirely different glucose response to that exercise or sport session if they're taking the Lantus or glargine in the morning than if they were taking it the night before. That's not me saying they should be doing one or the other. It is me saying that you need to know when they're taking their long-acting insulin, how that long-acting insulin works for them, and the timing of it in relation to their physical activity, etc. When we're working with athletes who are on pumps, and we'll have to come back and do a whole session on automation and the new automated systems. But if we're looking at somebody with traditional pump therapy, we've historically looked at trying to reduce basal insulin infusion by about 30% to mimic normal physiology. So you could do that by adjusting basal rates on traditional pump therapy by about 30%. And the real key here was you have to manipulate you have to start the reduction an hour and a half to 2 hours before the exercise period, because it takes a good 90 to 120 minutes for the insulin levels to settle down. So that's something we frequently see misunderstood, that a pump rate change is made at the, right at the beginning of exercise or activity, whereas it really needs to be started prior to the activity. And now we have these amazing automated pumps that have exercise modes and temp targets, etc. I think they are good, starting places for our kids and teens who are on these systems. But these are early iterations, and they're not prime time for exercise. So my biggest take-home point to you would be that don't be fooled into thinking that an exercise mode or attempt target's going to be everything that they need to do, and they can just flip into it and everything's going to be fine. I don't think in general there's enough of an insulin reduction in those modes, and these kids and athletes are still going to require carbohydrate fueling and supplementation to sustain their glucose levels. Just a quick word about basal rate reductions versus insulin pump disconnects. I just want to show you, and this is just simple data out of a couple of different trials. It's hard data to come across actually, but I just want to remind you what will happen to your athletes' insulin levels if they disconnect from the pump versus do a basal rate reduction, because they're entirely different scenarios. And we have a lot of athletes, especially in contact sports, who disconnect from pumps, and they end up with very low insulin levels that wreak all kinds of havoc, especially 1 to 2 hours after practice or the game, when the glucose levels go to 400 or 450 or whatever, if they've been off the pump for a couple of hours. So if somebody disconnects from a pump, here's some data on what may happen to insulin levels 1, 2, and 3 hours after a pump disconnect versus a 50% basal reduction on traditional pump. With the pump disconnect, insulin levels decrease by 50% within an hour and up to 70% within 3 hours. Whereas if you do a basal rate reduction, the insulin levels are only decreasing about 15 to 25% over the course of 3 hours. So you have much higher circulating insulin levels if you're doing a basal rate reduction versus a pump disconnect. And it's much more physiologic. So we understand that pump disconnects are a mechanism for decreasing the risk for hypoglycemia, and sometimes it's pretty successful. The challenge that we run into with our teens, and Dr. Anita can speak to this probably better than I can, is that they don't usually disconnect from the pump for an hour. They usually disconnect from the pump for an hour and a half, 2 hours, and then they get home and then they play their Nintendo, and then they're like, I'm going to grab something to eat and I'm going to grab a shower, and like 3.5 hours later, they're like, oh yeah, I got to hook up to my pump. I don't know. It just kind of, the insulin levels can get very low and it can wreak all kinds of havoc. And this is just another graphic demonstration, and it's probably a little bit too much for this talk. But what I wanted to show you here is in these 2 red lines, if there's an insulin interruption or a pump disconnect, the first red line on the left at 2 hours after the pump disconnect, you can see that the plasma insulin levels have cut in half at 2 hours. But look at the middle glucose curve. The glucose, these are people at rest, but the glucose level doesn't really change too much. So sometimes when insulin levels decrease a lot, you don't really see metabolically what's going on just by doing a finger stick or looking at a number on a Dexcom, because you can see in the next 2 to 4 hours, as insulin levels settle down a little bit more, glucose levels start to take up into the 200s, and ketone levels, although not at a dangerous level, really start to take off 3 to 5 hours after the pump disconnect. And these are people at rest. If you have a pump disconnect for 2 or 3 hours and you throw on a catecholamine surge related to physical activity, these numbers are also going to look dramatically different. So the pump disconnects are challenging, another challenging thing for our young athletes with type 1 diabetes. And it creates a whole lot of havoc and chaos in glucose control, particularly in the 2 to 4 hours after the pump disconnect has occurred. So it's kind of a tour de force. I know it's a bit of a whirlwind, but I hope that there's some practical applications that you can glom onto to help think about how to decrease the risk of hypoglycemia in your students with type 1 diabetes. Obviously, from the initial data that I showed you, optimizing the starting glucose level is important, but it has to be complemented by optimizing the insulin level, and then starting conservatively with some intermittent carbohydrate supplementation. It's not a failure or a fault need to consume carbohydrates to sustain the glucose levels. It's just a necessity because the body can't mobilize the fuels the way they do in normal physiology. And to the best of your ability, if you can help your students and student athletes separate exercise and or training. I know the spontaneous activity is very hard, but if you can separate out exercise and training from their meal and snack boluses by 3 or 4 hours plus, it's really going to help their cause. We apply really general sports nutrition principles to our athletes with diabetes, and they're the same as those for athletes who don't have diabetes. And there's really no need for fuel consumption in the hour or two before exercise when it comes to the sports performance point of view. If your students are going to be exercising 1 to 2 hours after a meal bolus, strongly consider, I'd say, a starting point of a 50% reduction, depending on the duration and intensity of the activity, and then monitor the pattern and the pattern response and see how that goes for them. Most of your active students with type 1 diabetes will need some carbohydrate consumption to decrease the risk of low, and the amount that they'll need, at least in part, will be based on how much of a peaking insulin they have on board. And as much as possible, as hard as it is, as much as you can help your students and student athletes avoid hypoglycemia and strive to keep them above 70 milligrams per deciliter, I'd even try to keep them higher. I'd say try to keep them above 100 because hypoglycemia is really a vicious cycle. Again, another lecture onto itself, but hypoglycemia is a really vicious cycle, and it just sets the kids up for further bouts of hypoglycemia. So I really want to thank Sarah and the team for inviting me to speak tonight. It's a privilege to be here tonight. I know the schedule's tight, and I've already probably eaten into my friend Anita's time, but I'd be happy to try to answer some questions or answer questions offline at a different time. And I just ask you to keep in mind too that the foundation is out here, and we'll be hosting our next teen boot camp, which is really unique for teens and their parents with type 1 diabetes, August 6th through the 8th at Spooky Nook Sports in Lancaster. And you can email, Sarah can get you our information. You can email or call us directly, and we'd be happy to answer any questions. So thank you, Sarah. It's a real privilege.
Thank you very much. That was really informative, and we really appreciate you being here. I have a few questions in the Q&A box, and there's some that are kind of similar, so I'll kind of combine. What types of carbs are recommended, and do you have snack recommendations for exercise? Well,
we generally speaking, during sport or exercise, you're going to look for rapid acting carbs. So the athlete has to be able to tolerate them. We have a lot of athletes who just use liquid carbs. So even if it's carbs from some form of sports drink or Gatorade, where they can quantify how much they're going to get, the gels and gummies work very well. You just want to avoid, the complex carbs and the ones that are going to be slower to absorb during exercise. So simple, rapid acting, and something that the gut is going to be able to tolerate pretty easily. And then it's real important that they learn, and this is hard, I know, especially with the teens, but to learn to try to separate them out, that we're not asking them to consume all of this at once. We're trying to teach them how to separate this out over a period of time.
Awesome. Joan Atkins said, I was recently told that diabetic students on sports teams are not permitted to wear their pump during competitive sports, so they could not do a basal rate decrease, but are forced to stop insulin throughout the entire competition.
Yeah, I would. Dr. Swamy can fill me in on this, but I think they're deserving of every accommodation that they could possibly need to wear their pump if that's what they want to do. If they're going to be off their pump by their choice, and they're going to be off their pump for several hours, then they probably ought to think through, how can I get some background circulating insulin through another means? Like, maybe those are the days I want to take a little bit of a long-acting insulin subcutaneously so I can disconnect from my pump, but not lose my whole insulin supply. But I would say that should be by their choice, nobody else's choice, and they deserve the accommodations. And I think by law, they should get the accommodations.
I would just echo what Dr. Corcoran said. So we suggest that they have insulin throughout the sport with rare exception. And it's usually the child or the parent that prefers not having it, probably because of a history of not having had the pump and being used to playing without having insulin going. So they kind of ride high. But I think that's more of a one-on-one conversation. It's not a global rule. In fact, our rule is really to give them the accommodations because that's their right. And that's what ensures that they play at their best level as well. So it's best for everyone to have insulin throughout the sport.
Awesome. Okay, let's do one more. So too often we just talk about carb counting. I came to your program around 7, so you may have discussed this. Where is the protein fat that should be consumed with the carbohydrate to help slow down the impact of the carbs? Also, could having a higher fiber carb impact the use of the carb?
So I'm not, so those components would come at other parts of the day. And are really important to the general nutrition of the kids and the athletes, but they don't really have a role in terms of sports nutrition in the moment to help fuel the working muscle and or if it becomes a need to prevent or treat hypoglycemia.
Okay. I also mentioned
that's just how I see it.
I meant to mention too, tomorrow night, our second speaker is Tina Trout, and she's doing an entire session on pump education. So, and I know Tina's on tonight. So Tina, maybe you can look into that if it's a Delaware thing or if that's not even necessary because the accommodation would be there. So just to touch on. Well, with that, Dr. Corcoran, thank you so much for being here. And Nina, you have your hand raised, but you have the ability to unmute and speak. So if you if you want to.
I just want to say, is that something that should be in an IEP for these kids, Dr. Corcoran, to be able to decide how they're going to wear their pumps during exercise? I mean, we did a program last year on the ADA accommodations, and Dr. Swamy has addressed the accommodations issue, and maybe you're going to talk about that. But these nurses are very, very, very in touch with the IEPs, and so I just wondered if that's something that can be addressed in an IEP for them to be able to do that during exercise.
So, Matt, do you want to address it?
No, go right ahead, Anita.
So I think that's an excellent point. It is safest if it's addressed in an IEP so that we can make sure they're allowed to do that. And the question doesn't come up if there's a substitute coach or someone who's not aware. And the IEP, obviously, as you know, is the conversation between the family, the patient, and the school as to which accommodations are necessary, appropriate, and feasible. We can also put it in the DMMP. So in the medical management plan, there's sort of two components. And that is more, what does this person need while at school and school-related activities? So if that's something that comes up and we need it in both, I think it's completely reasonable to put it in both and probably the safest.
Right. Awesome. Well, thank you so much. And with that, Dr. Corcoran, you're welcome to stay on and listen to Dr. Swamy here, and
can't get enough of her.
Yeah, good. So Dr. Anita Swamy is an assistant professor of pediatrics at Northwestern University Feinberg. Swamy.
Sorry, Swamy and Feinberg.
Oh, sorry.
No,
thank you.
You're fine.
Swamy, Feinberg School of Medicine. She also practices as an associate clinician at Ann and Robert Laurie Children's Hospital of Chicago and is vice president of medical staff and medical director of the Chicago Children's Diabetes Center at La Beta Children's Hospital. I don't know how you have time to be here this evening. Those are a lot of big jobs. And then prior to this position, Dr. Swamy founded and was the director of the Pediatric Diabetes Center at Advocate Hope Children's Hospital in Illinois. So we are honored to have you with us this evening. Thank you so much. She was in Phoenix about, I don't know, 5 hours ago. So,
Yeah.
and is now back in Chicago. And that's the power of Zoom. And so we really
That's right. I'm
appreciate
so
you being
grateful.
here.
Thank you so much for the wonderful intro, Sarah. And I just want to do a quick shout out. For people that may want more of this education, I've been working with our JDRF associates to create a national education program for school nurses. So if you want more information, I'm happy to put it in the chat as to an email contact for that. We will be having them routinely. So throughout the year for both medical professionals and non-medical. So parents, grandparents. So if you feel like there's a family that can really benefit from education, they don't have to see us. This is a national program and it's free for the non-medical. For medical, we give 5 hours of CEU. So I think it's like 20 or 25 bucks, which if someone can't do, we can accommodate for that. So just a little pitch, and then I will put it in the chat as to the person to contact. And it's our whole team who actually conducts it. And so we talk about the background of type 1, insulin, glucose, DKA, nutrition, exercise, as well as psychology of type 1. So we actually have one of our psychologists speaking, 504s and IEPs, and then I do a talk on technology. And so with that, I get to speak with you all today about, I think, a very cool topic in that it's something we don't discuss very often. And that is the feelings behind type 1. What have we learned as providers for these children with type 1? And what kinds of things should we be aware of when treating them? And I have been in this I'm almost 50, so it's been a long time. And I will say that every time I do something like this, I learned something new. So I didn't know this, and I don't know that I approached it with the right words when I was first a physician, but I am learning and getting better. And I think that's what this is about, is being able to help these folks. So here we go. It's not easy having type 1. These are some of the topics we'll discuss and time allotted. So if we go over, that's okay. We don't have to cover every single thing. And as you know, type 1 is a full-time job, and not just for the person who has it, but everyone who touches them, loves them, and cares for them. It's an additional burden, and the kid with type 1 feels that the most. So I just always am reminded of that burden. And the first thing that I've learned in all these years is never say a judgmental statement, because they carry that with them for a lifetime. And I just saw, and I have done it too. So it's not to say, I'm better than thou. I'm saying this from experience, even with parents. So I feel like these people are doing the best they can. And I haven't been in their position. In fact, I'm the mother of 2 little kids, and one of them is sick. And I had to pick him up, and he's over here. So I feel like if I had a kid with type 1, I'd be doing that constantly, right? Because if they have high glucoses, low glucoses, you're always running. So I think that what time has taught me is patience and understanding and some sympathy or empathy for these folks. So these are just some of the things they have to consider: is glucose checks, carb counting. What does that lead to? When you're obsessing over food so much, you are also forced to eat when you're not hungry. You're forced to not eat things you may want to eat, or you're judged if you pick up a donut. I had a patient at the airport, and a guy saw her get a bagel, and he saw a pump on her arm and said, "Hey, you're not supposed to be eating that. You have diabetes, don't you?" And it's just things like that that really wear on them. So when they hear all this, it's very natural to think they probably have an abnormal relationship with food. And in fact, it says 17 to 50 because we've done 1 million studies, but I would say it's at least 30 to 40% of people with type 1 diabetes have an eating disorder. That is a lot. And it is not the type of thing where you will always see it present as anorexia, but perhaps cycles of anorexia and bulimia, abnormal relationships where they gorge food at certain periods of time when you're not looking and may not eat during the day. Diabulimia is a term we use for insulin emission. So purposely, children may stop taking their insulin, because guess what happens when you don't take your insulin? You lose massive amounts of weight, because you need insulin to actually absorb the calories from the food that you eat. Not just carbs, but really all of the food that we eat requires some form of insulin to get the full calories, because it's usually eaten carbs with some protein and some fat. So mainly the carbs, but these teens figure out that it's a quick way to lose weight. So we used to also call it prom purging because it would happen right before prom season. So we know in our clinic, and we've taught our medical assistants, and something I share with everyone, if you see a person with diabetes who has changed their appearance, don't comment on it positively or negatively, but rather neutrally. Because if we say, oh my gosh, you look so great, then that's just reinforcing they're not taking their insulin. And then predictors of this are higher BMIs. So kids that are constantly told that they might be overweight or that's discussed. So now instead of saying, hey, you gained 7 pounds, we start off conversations like, let's talk about some of the topics that you are willing to discuss today or would want to, and tell me what you don't want to talk about. And that way it's in their court and we're not upsetting them. Yes, medically it's important, but I think if we let that patient or the family guide a little bit, they feel like we're not judging them. Some of the predictors besides BMI is depression and things that you can see here. In general, people being very concerned about their appearance. I kind of sense this when I talk to kids about wearing a sensor or a pump. I think a sensor is amazing. I am a huge proponent of the sensor. And I would say about 95% of my patients have one. And I think it really does alleviate anxiety. It leads to better outcomes. But there's a small percentage of people that really do not want it on their body. And so that leads to a different conversation. And inevitably, we talk about their relationship with food because they're all linked together. So if you see people that absolutely won't wear one because they don't want someone to know they have diabetes, that is a whole different conversation. And we need to talk about it with them. I should have started this whole thing by saying thank you. I think the role of a school nurse is as critical as any of our roles. So I very much appreciate your being here, wanting to learn this information. You are the person that sees these children, honestly, more than probably anyone else, sometimes even their parents. And we are grateful as medical professionals to have you on our team, because prior to things like this, we really would just send them off with pre-mixed insulin and 2 doses and pray that they did fine. And no one really even checked a glucose. So I realize the pendulum is swung and you have a lot more responsibility to bear, but it is in the best interest of this child. And we're actually seeing it in outcomes. So these kids are living longer, happier, healthier lives. They're able to achieve much more. So thank you. Okay, and then identifying this disordered eating, we talked a little bit about it, but if they dramatically change their diet, I'm going vegan, or I stopped eating altogether except 1 meal a day, and then they withdraw more and they won't inject in public, they're exercising incessantly. I have a kid that I saw by telehealth because of COVID, we couldn't see patients, and she looked very different to me and I couldn't say anything on the screen. So I called the parents after and I said, I think there's something going on. And sure enough, she had lost 30 pounds from when I had seen her previously, and she was small to begin with. So we identified an eating disorder and got her help. And I'm happy to say she is back to her baseline weight and doing much better after 1.5 years. But this does lead to DKA because, as you can imagine, they stop taking their insulin. So again, we never say, hey, you look great, because that might come with an A1C of 14%. So again, this balance is very tough. So one of the things that occurs is burnout. And what contributes to burnout is, why don't you do this? It's so easy. You just have to take your insulin, right? So things like this that they might hear constantly, or nagging. Kids tell me all the time that I am diabetes. I'm no longer, Anita. I am, what's your number, when I come through the door. But my parents don't say that about anyone else. And in fact, nobody around me says that about anyone else. It's just when they see me, they see diabetes. And that, again, is something really tough for this person to have to deal with day in and day out. So we coach our families on how to talk to one another. And we are learning as we're coaching. So when I say we, it's our psychologist and our social worker. And I'm sort of listening and saying, okay, I'm going to try that. But it's really saying, how can we make this better so that you talk to your son about his day at school first, and then we may bring up the diabetes so that it's not like he's being attacked. And then the parents often are exhausted, and it's usually one parent who carries the burden, right? So they're sort of blamed when things don't go perfectly, or they feel at fault and blame themselves. To that end, we've created these virtual training programs with the encouragement of the whole family to come. So I insist upon that, so that this burden doesn't lie on this one sole parent that holds that responsibility, and they can take turns. So We also say that when the kid has a sensor, this is something new I started doing, is discussing with whom they share that data. Because everyone just assumes they're going to share it with everyone. Well, you don't have to. And it really depends on how that person reacts. So if they're stressing you out with 20 texts a day, maybe that's a conversation we need to have about what's appropriate. And these are things we never trained on, right? The sensors didn't even exist when I was in training. So it's really, again, new for all of us, and we're adapting. But when these kids burn out, we see that their A1C goes up. They don't check glucoses. Thankfully, sensors have really made it so the glucose checks aren't as common, but sensors fail, they get lost in shipment, or they never get them. So it's still important for them to know how to do a metered glucose check. And then they may tell fibs. So one of the benefits, again, of the sensors is that you can share the data in real time. So there's no making up information. But when we used to do glucose checks, people would always say, my numbers are great. Or parents would say, how are they? Great. And then we'd come in and the A1C was 13 and everyone would melt down. So thankfully, those situations are a little bit rare, but still occur. So what I tell parents is, just like everything else, like your bills every month, anything we're responsible for, do a check-in. So do not just leave this enormous burden on this child. Do a check-in from time to time. Make them know that they're doing a good job just for doing the work, and recognize that. And then help them. Say, hey, let's come over here and just do this together. I'd love to check with you, and maybe you can check too, so they can see that you're willing to tolerate that same pain or burden, just to show them you support them. And we do tell people they can take a diabetes vacation. So sometimes we'll tell our patients that are overwhelmed, maybe even though you're 16, maybe your parent can help you for a week where they just do your checks and do your boluses. We often see that they don't do their site changes, and that is something that comes up on their pump site reports, is how often they change it. So we talk about that. And then ignoring alarms. That's a big one. A lot of people ignore alarms because they're going off too much. So one of the other things that people also don't realize on CGM therapy is that I can change those alarms, and that's really important to do. It is not a one size fits all. I do not want everyone's alarm to go off when they're under 80 or over 180. If you are living at 250 and that's when I met you, maybe a good agreement is your alarm goes off after 300. And that way we get to 150 without you being really annoyed with this instrument and throwing it out the window. So these are all things, again, that are modifiable. So if you feel like there is a child whom you interact with that constantly has alarms going off and they hate that, or it's bothering you even, I would say we can change those. It's in the settings, so that it's a little bit more user friendly. And then as their control becomes better, we can tighten it back. And then as far as autonomy, I think that is the $1 million question. So people are always asking me, at what point can they do this themselves? Well, honestly, I have 2 kids, as I said, and I don't know if at any point I'm going to feel like they're totally fine. They don't have diabetes. So I feel like when they have diabetes, that's one more layer where obviously we want them to be independent and strong and empower them to make their own decisions about their diabetes. But we don't just fully let go and say, this is now only your job. I think supportive supervision is the key term that I use. So just because you give them some autonomy does not mean you necessarily have to think they're responsible and capable to do it all by themselves, but you can give them small, independent tasks. And as they achieve them, they can get more and more autonomy. Uh-oh. I don't know why my screen isn't advancing now. Sorry, guys. There we go. Okay, so this is data that I think is disturbing yet reassuring to see. And this is from the T1D Exchange, which is a national registry of people with type 1. And in this particular study, we looked just at their A1C. So as you can see, the A1C is the highest in the mid-teen years. What does that tell you? This too shall pass. So that is what I tell my parents is, A, it's not just you who is a hot mess, but it's all of us. And B, it gets better, and it gets so much better. But this is the hardest time. And in fact, the time when maybe they're trying to pull away the most from you, this is when they need most support. So I think it's really important to emphasize that and reassure them that they're not alone. And it really is not different between boys and girls. And then as far as what can we do to prevent burnout, we can notice. So when a person is not talking, when they're looking like they lost weight and probably didn't intend to, or just looking sunken, those are times I'll just go and do a sugar instead of asking them to. Ask them what we can do to help instead of saying, why didn't you do this? And then as much as possible, communicate. And if you feel like parents are not willing to listen, I think as providers in a team, we would like to know and help as well. And then finally, congratulate people, because most of these children have been carrying this burden for years and years and years and years without a day off. So I think they need to be rewarded for the work that they do. Okay, like I said, we're going to go fast, and there's all these very interesting topics. So one of the things that we talk about, and I start this at age 12, so as alarming as that may seem, I think it's important to recognize that this happens at a very young age, no matter where we are. So I'm so sorry, my little guy is banging on my door. Okay, so what happens with alcohol? So what I usually do with my kids is say, okay, if somebody offers you a beer, what do you think that does to your sugar? And how can you handle that in terms of your insulin and your glucose? And I say, well, I'm not going to drink beer, Dr. Swamy. I say, well, I know if someone forces you and you really don't want to, what would you do just in case? And say you're 21 and at a party. So I think that's a good way of saying it, rather than teaching them, is giving them a case scenario. But what alcohol does is actually shut down the liver. And as you saw in Dr. Matt's presentation, the liver is a critical organ in regulating your blood glucose. So what happens when I drink and I shut down my liver is now I have no more glucose stores. So if you drink repeatedly and you actually bolus for those drinks and you shut down your liver, even if you ate before, the most likely scenario is that you will have a severe low or hypoglycemic event. So we teach our kids to be really careful. I say that this is tough, and I realize that you want to be like everybody else, but it's really important that you know what can happen. These are the days that you have a buddy and you tell them that you're drinking and you have type 1. Ideally, you're wearing a sensor. If you have a close enough relationship with a parent or some other adult that you trust, then you share your data with them and that night and say, please just look out for me. I'm going to have 2 drinks. You can't do a kegger. I say, I'm sorry to burst your bubble. And, you know, I grew up as an adult, never did one. So you can still be kind of okay. But it's really a bad idea to have drink upon drink upon drink. So I tell them to alternate an alcoholic beverage with a non-alcoholic. And I think those types of tips really help them. And it's things they never think about. The other thing is that they need to fuel when they drink. So I do tell them that they need to have snacks available. When it usually hits them is overnight. So I want to make sure that they are able to hear their sensor alarms or with someone who can and knows what to do. And then we'll go to the next slide. This just tells you the carbs in the drink. So we also say to try to avoid the super sugary drinks, because those will make you have hyperglycemia, and then eventually you'll have hypoglycemia. So I think it's best to have the lower carb drinks altogether. And then we talked about this. So don't drink alone, drink with a friend, don't drink on an empty stomach. The other important thing that we should note is if you do have a high carb drink, don't bolus for all the carbs, because then again, you have that same scenario where you have all this insulin on board, but then your liver is not releasing sugar. So you're going to have a low. And then glucagon, what is it? It is a hormone that actually works at the level of the liver internally to release all your glucose stores. But we just talked about the fact that the liver is not working optimally when you're drinking. So glucagon may not help like you think it should. So we also teach people that yes, have your glucagon, but you probably won't have the same effect. So just be prepared to have something with glucose around, and then always wear your medical ID. As far as marijuana and vaping, this is increasing dramatically, and it's really concerning to me. There's lots of risks, and so we just educate our patients about it. I just ask them to be open and truthful with me, so at least I know what's going on. We don't have a ton of data on marijuana, but I do have case reports. Although it says that there's no known effect, I've had 2 patients now that have profound hyperglycemia due to smoking pot constantly. out of the blue. So they needed massive increases in insulin doses, and I couldn't explain it. Finally, put them in a room alone. I said, you need to be, upfront with me. You need to be real with me. I just need to know so I can help you and your organs. And then they told me. So I've had 2 of these experiences. They can have DKA. And then vaping, we know, besides increasing your A1C, damaging your kidneys actually, can cause profound pulmonary issues. So I've had now more than one kid who was admitted to the hospital with profound pulmonary compromise due to the vaping. So these are things that we discuss with our patients. And then I like this. So I have to credit my colleague who actually created this slide deck with me. She has type 1 diabetes, and she's at Barbara Davis Center, Dr. Simmons, and she put together these funny ones. So if you find them as funny as I do, please comment to her, and I'll pass it on. I'll do my best not to judge you after the ignorant comment you just made about a health condition you know nothing about. So I'm sure that we can apply this to lots of things, especially with COVID today. But I think it's really important that we arm our patients with how to talk about their type 1. So to that end, we have a lot of awesome resources. JDRF and College Diabetes Network actually have some resources about how to come out about your type 1 and tell other people that you have it. And you have to kind of practice the conversation. So we do that as well, especially before they go to college. So they know how to tell somebody the difference between type 1 and type 2. Yes, they can have a donut. This is what I need you to know as my roommate is how to use this glucagon. This is my fridge for my insulin and my juice. You can't touch that, and why. So we work through all this. So just know that there's resources. And I think College Diabetes Network is an awesome one, even if they're not going to college. And then as far as driving, this is very variable by state. So I practice in 2 states right now, Indiana and Illinois. Illinois has a law that I have to sign off on the license form in order for my patients to get it. Indiana does not. So I just tell them the rules of driving. One is you always have to have a meter and or a sensor with you at all times, so we know what your glucose is. You have to have some type of medical alert. It can even be a card. It can be something that's kept in your wallet. It can be a tattoo. I mean, I don't care. As long as people are aware that you have diabetes. And then we also have different things like commercial licenses. So there's various laws that apply. They need to have treatment on their person and in the car that's non-perishable. So juices are not ideal, but maybe glucose tabs and other candies that don't melt. So this is just actually going through all of that. Never check your glucose while you're driving. Please pull over if you have a low, especially, and then treat that low, and always have treatment in the car. Okay. And then now we're going to flip a little bit and go back to the depression, anxiety. This kind of goes with the eating disorders that we discussed. So we need to screen for this. And it's really important that we have teams that are equipped to manage a kid holistically. So it's really treating type 1 as this much insulin and blood sugar and this much social, emotional, school support. So I think this is really the most important part. And it's in our standards of care. The rates of depression, anxiety, sleep disorders are 2 to 3 times that of the normal population. And we see it in up to 1/3 of kids with diabetes, and that's what's reported. I would tell you that with COVID, I doubled that. It's been much worse. And usually it's associated with a higher A1C, and about 1 in 5 of them have anxiety, which you can probably understand because all day long, what are we telling them to do? Do something based on a number and constantly look at that number. So CGMs, I told you, are awesome, but they also give me a glucose every 5 minutes on even my Apple Watch. So that can really stress someone out when they're trying to take a test or play a game in the game of their lives when they're being recruited. So just kind of keeping all of these tasks in our mind about what they go through day in and day out, it's exhausting. And there are specific anxieties we see quite frequently: injection anxiety or infusion anxiety, and then fear of hypoglycemia. I think the hypoglycemia is actually the biggest one. So we'll talk about that. And that will come to. But before I get to more about this, I do want to address the hypoglycemia is also in the parents. And I would say probably even more than the patients, or perhaps that's the impetus for the patients to have this. I do think that our sensors have really mitigated it. But now these people are obsessed with looking at that number. And when that patient is dropping, even if it's dropping down from a high to a normal number, their tendency is to treat when they see that down arrow. So kind of working through all of these things and saying, what is the thing that worries you most? How can we maybe come to a middle ground on this? Because your kid's higher sugars are also hurting him. And now we have an indication of when they go low. So maybe we can come up with a middle number where we treat. So we have these conversations all the time. I also think that's why it's really nice to do these sort of seminars, because I don't get to cover all of this in a clinic visit. We also have something called Type 1 Nation, which is a meeting that occurs in each major city, probably near you as well, through JDRF, where we talk about all of these things. So I tell people to go as much as possible, because then we have more options and opportunity to share. So what else we can see with depression is changing in appetite or sleep. And they start doing poorly in school. They do express that they might want to hurt themselves or someone else, and irritable, and they just stop doing diabetes care. And so I just kind of talked about this. They might also go to you all of the time, whether they need to or not. So what do? Therapy. And thankfully in our institution, we have them see a psychologist upon diagnosis just to set up that relationship. But unfortunately, the ped psychologist is like a rare, nearly unseen entity, because there's not many of them. So even if we can't have a formal psychologist, I think just a therapist, social worker, somebody who is licensed to talk to these folks and the kids is really critical day one, because then they have that relationship, so that going forward, they can always go back to that person periodically and set up relationships. So seeking help early is important. Having someone in place early is important, and teaching them coping skills. We also do this with diabetes training camp. Actually, there's a lot of mental health providers there. So if you have any of your children are interested, or they don't actually have to be an athlete, I certainly am not one, and I participate in the camp. But I think it's far more than a training camp to teach athletes how to exercise safely with diabetes. It's really a community. And I can't say that enough. And I joined years ago, and I'm grateful to have done so. And then we also evaluate to make sure they don't have something else going on, like a thyroid condition that may be contributing to the depression or anxiety. Okay, needle anxiety. So how many times does a person with diabetes have to stick themselves? So let's see. Let's say they're not wearing a sensor. So 4 to 6 times a day for finger sticks, and then maybe 5 shots a day for meals and snacks. So you're talking about at least 10 times a day times 365 days per year. If you wear a sensor, take out just half of that. So there are thousands of times per year that this person is having to stick themselves. And if you can just imagine in a lifetime, it's tens of thousands. So, and these are in children. So I think that they develop a significant phobia. And here we're talking about the type 1s that are newly diagnosed, but I also see it in people who have been diagnosed for a long time. They're just done. And in the initial stages, we have some things or tactics that we can do to mitigate that. So we'll talk about it. But it often resolves, thankfully. We do have a lot of coping mechanisms. The thing that we see most commonly as a result of not wanting to inject anywhere else is lipohypertrophy. And that's just, it looks like a bulge because they're injecting in the same place all the time. So if I see kids that look like running backs, or they've got massive, humps on the back of their triceps, and they're not bodybuilders, on the back of their arms, where their triceps are, then I say, let's talk about why you're injecting there and what's really happening to that skin. So explaining it instead of saying, oh, this is terrible and you can't do it there, that's not going to change their behavior. So just talking about why is it bad? It's because it actually hurts the tissue that's there, and it might permanently get damaged. So maybe we can try an inch or two away from there. And then they might tell you that they have bruising or bleeding in certain locations. So just trying to find out why they're injecting in the same place. And then we have a lot of techniques that we can do in clinic and with therapy. One of the easy ones that we use that I want to talk about is Buzzy. You can look it up. In the interest of time, I can't go through all of it, but it was actually created by Dr. Mom to help alleviate any injections. So vaccines, but any real pediatric injections. It's a distraction technique. And I actually think it's pretty effective in little kids. Okay. And then we talked about this. So parents having fear of hypoglycemia. So it's really more than moms than dads. I think actually anecdotally, we see more moms present for the education, not in a sexist manner, but it is actually what we've seen in history. So the onus is on this one parent. We see lots of dads, but I think it generally tends to be that way. So that is why we sort of insist that maybe the other parent attend this session or a grandparent. If you have a fear of hypoglycemia, usually we see it when patients have a lot of hypoglycemia. So they're usually kids that have been on NPH or premixed insulin before because they were diagnosed when they were 2 and we didn't have anything better. So they remember what that was like. They've had a low at an embarrassing time. So at school, nobody wants to experience that. So they'll never do it again. And the longer they've had type 1, as I talked about, if they were diagnosed a while ago, they have a higher risk of having a low. Thankfully, I have a handful of kids this year only who have had significant lows. And every single one was when they were off their sensor for various reasons. Usually it's because they played some kind of sport, it fell off and they didn't put one back on right away. They said, I'll do it the next morning. And then they had a significant low overnight that wasn't detected. In the era of sensor therapy, I have my frequency of hypoglycemic events that lead to some intervention, which is called a severe hypo. I mean, I think it's gone down by at least 50%, if not like 80. And then this is something that we can say to each other, right? And we often will say, how are you? And person says, oh, I'm fine, I'm good. But you're really not. So you're not answering that question. But when we ask someone with diabetes, how are you? They will often do the same thing, I'm fine. But really, this might be what they're feeling instead, is all the words in blue. I'm ready to give up. I'm anxious. I'm bitter. I hate this. I don't want it anymore. I feel defeated. I'm exhausted. I'm confused. I don't get why I have to do all these things. I'm tired. And so we're going to talk a little bit about this transition, changing from one state to another. So this is at diagnosis. All of a sudden, you are somebody that is sick. You were playing and you were happy and you went to school and your only responsibility was to have fun and learn. And now all of a sudden you got to take all these shots and check your sugar and you're diagnosed and people give you tons of attention for 2 days maybe. And then you go home and it's like peace, like that's it. And now you got to see all these doctors and your whole life just changed, but nobody's really talking about it. That is quite a lot. And it's a lot to go through. And there's guilt and shame on the part of everyone. Usually parents say, you know, well, it was on his side. No, it's on your side. They're overwhelmed. So we have found that we do outpatient education right about a week after inpatient education, and it's the same information. Because what happens when your child is ill is it goes in one ear and out the other, and you can't hear it enough. And then the first question that's in their head that they don't want to say is he going to die? So when I start off meeting parents, I will often talk to them alone and then the kid and say, he's not going to die from this. We're going to make sure he doesn't. He's going to do everything you wanted him to do, and he's going to be just fine. And you would be amazed at how many people just bawl upon hearing that, because you know that's there and they didn't want to say it out loud. And also saying, what is this? Why did they get it? They're confused. What is the difference between this and type 2? Did I give them a cookie? I mean, there's just so many things in their mind. And then I also mentioned, that's not on here, is the relationship between the parents is now really strained. So when I see a kid back after diagnosis in the family, I spend a couple of minutes saying, how are you two doing? Just because we might ignore that too, but I need them together in order for this kid to succeed. So the other thing is tangible issues. Like, can we afford this? What kind of insurance do I need to get this sensor, Dr. Swamy? How much does it cost? How many times a year do I need to see you? And can I see you until, forever or tomorrow or when they turn 18? How do I get my scripts? So there's so many things that they have to deal with. So these are all of the stages that they go through. And as you can see, it is the stages of grief, but it's really relevant to the diagnosis. And it takes quite a while for them to get to that end point. And just because you think someone's got it, it changes as they get older. So in my adolescence, I talk about dating, body image, driving, alcohol, going to college. In my little ones, it's about friends, telling people you have it and not getting bullied, about eating. So very different things about how to be more independent and giving your own shots, perhaps. So grief, I like this. Grief is like the ocean, again, from Kimber. It comes in waves, ebbing and flowing. Sometimes the water is calm and sometimes it's overwhelming. All we can do is learn to swim. I think this very beautifully applies to the diagnosis of diabetes. So there are support entities out there, and I think they're awesome. So I tell people that it really does take a village. This is the village. So I want them to engage, even if they really are like, I don't want to do this, kumbaya. But JDRF is wonderful. They have tons of resources. The woman that I work with to do the national meetings that I emailed in the chat is Elle Riley at jdrf.org. We set up the Type 1 Nation seminars together as well. I think they have a lot of really neat resources to help families. We also have local Facebook groups that have formed their own groups. So usually there is one in the area. And I think that's really nice. Usually if there's some kind of new thing that comes on the market, I will actually post it to a local Facebook group so my patients are aware. Beyond Type 1, another amazing resource. They have so many tools, like what to prepare for when you're sick. How about when you're traveling? What if you travel internationally? How do I take care of that? So these entities have come up with all these wonderful tools for us to give our patients. American Diabetes Association, not just pediatric, but also adult, also type 2, because peds diabetes is not just type 1. And then, of course, DTC, so Diabetes Training Camp, again, an awesome resource, whether they're really truly in your head or in their head, athletes or not. If they're participating at all and they want to be active, I think they learn so much more than how to manage their glucoses. So disclosure, I know that I've been talking and talking. I promise I will leave some time at the end for questions. Okay, and let's see here, I'm sorry. It's not letting me get rid of my own little bar here. Okay. So disclosure involves the risk of telling people and opening yourself up. Okay, hold on. Sarah, I'm sorry, just give me one sec. There we go. And that means that you're vulnerable and you're willing to share this. So it really is hard for people as they get older to do this. And there's also conversation about if you're dating, when do you tell someone? Are you supposed to tell someone the first time you meet them? Do you want them to know this private information? So we talk through these scenarios with our patients as well. So there is a real big need to see your patients alone at these ages. And then whom do you think you should talk to? So it's always nice to be open with your medical team or your school nurse. So the reasons that we should inform people is to be safe, really, be closer to them. It builds trust, and so they can be part of the support team. There's less ignorance. I tell my patients that if you show up to this Type 1 Nation event, oh my gosh, all of these little kids that were just diagnosed get to see you and how successful you are, and they're going to know that they're going to be okay because of you. So it's important for people to pass along what they know, just to walk around and say, yes, I have Type 1 diabetes, I'm this, I'm that, I can do it. And when people see evidence of that, sorry, you guys, my husband moved all our plants into my office. And there's these gnats that are flying around. And to get what you need. So it's really important to have, as one of the nurses mentioned, do I put this in my IEP? Well, it's important for everybody to know this and that it's relevant to your care. So to get what you need, we need to talk about it. How do you tell someone? What do we want them to know? Create an elevator speech. Hey, I have this. It means that I don't make insulin. I'm not sick. As long as I get my insulin, I'm fine. The way I check if I'm getting enough is I have these sugars that I have on my meter, or I can get it through my sensor. And stuff like that. So if there's a roommate, JDRF actually has a letter to your roommate online that you can Google. So it's pretty neat stuff that's out there again. But we work through this with our patients too. And then this is just an example of a person without diabetes and a person with diabetes and all the other things they have to think about. So a person without diabetes might say, yeah, I wonder if there's something good on TV. I should really think about where to go for the weekend. I should work out today. Traffic stinks. What should I make for dinner? Now it's a person with diabetes. Do I have enough snacks with me for this event or day? Did I give insulin for that last thing I ate? Everything that a non-diabetic thinks about, plus these things. What is my blood sugar right now? What if I go low? How do I treat it if I go high? When's the last time I changed my pump? Am I shooting this into a puffy space like that lady told me? And so it just kind of goes on and on. When's the next time I'm supposed to order my supplies? So as you can imagine, this just gets to be grueling. So here is just another depiction of these activities involve every single part of their daily life: eating, bathing, dressing. You have to take your pump off if you're in a tubed pump, but you got to remember to put it back on. So some people don't do that. How many carbs are in this food? Carb counting has to be done like this, right? You can't just sit there for hours and look it up. Although we tell them to use all these apps, it's still one more step. So we got to make sure I don't shower right after I take insulin, because guess what? That increases my risk of low. So just all of these things that make them feel like if I say it, I'm different, and I really don't want to be different, especially at this point in my life. Now, Dr. Matt covered this beautifully, but I think it's also important here to stress that they also have to think about how they work out. So am I going to eat now? Do I bolus for this? What do I bring while I'm working out so that I don't go low? How often do I take that? I mean, it's easier for someone to say, I'm just not going to do it, right? So imagine being a kid and having to coordinate all this. So how do we integrate this and do it successfully? Really, again, it takes a village. So you need a supportive team at your medical office, at school, and at home, and among your friends. I think it's really nice to have these communities where they talk about type 1 with one another. So we introduce our patients to these groups while they're in clinic with us. I'll just bring up the Facebook site so it doesn't feel like it's as foreign, and I'm telling them to join somewhere else, like at home. We need to set goals and say, you know, by the next visit, maybe we can just share with one person that you have diabetes and see how it goes. And then rules, you have to make sure you enter for your carbs at lunch, even if you're at school and really busy. Communication. So instead of a parent completely ignoring the child and saying at the visit, I told you to take your insulin, and they're surprised at the A1C, why don't we just touch base with that child like every week and say, how's it going? Can I take a look at the pump? Can I help you somehow? And not always having it be where you're scrutinizing or yelling. And then using tools and technology, which have made it much better, but they still have to do with this. Relationships and dating. So I alluded to this briefly. When's the right time to tell someone you have type 1? Is there ever a right time? How do you tell them? How do you explain type 1 versus type 2? So before I get to this, I have a story, and it's one of my best friends. Dr. Simmons also tells her very own hilarious story about how she met her husband. But one of my best friends has type 1. And his name is Ben. And she was a resident. I think he was a cardiology resident. And she was really into him, and he asked her out. She didn't tell him she has diabetes. And they went to dinner. And she said, you know, I want to make sure my sugars are fine. And she anticipated having a long, big dinner with lots of food. So she gave herself a bolus because she's also really well controlled. And she bolused for like 75 grams of carbs. Well, what happened is Ben said something like, well, tell me why you chose endocrinology. By the way, she's an endocrinologist. And so she leads into this story. She gets distracted. He's super cute. They're smiling. She forgets about food. And she has a severe low. And they had ordered their dinner, but she normally asked for bread or something like that she bolused for. She ended up eating her dinner and his dinner at the same time. And although it sounds funny, it was mortifying for her. And so then after that happened, she's like, hey, I have to tell you something. And that's how she told him. So I think the point of that is there is no great way. These things may happen. So we probably should navigate it beforehand. So How do you explain type 1 versus type 2? I think that's a very good question that my patients always say, that people think they have type 2 and tell them what they can eat, what they can't eat. I don't know that they even have to explain it. They can just say, I have the kind of diabetes where I don't make insulin and I need it. And it's not because I ate something wrong. And my pancreas just stopped making insulin. So it is not like type 2. Do you take your pump off when you're intimate? So the way I know this as a doctor is if they have a tubed pump, I see that it's disconnected all night long, and it's usually in an older adolescent. So whenever I see that on a download, I say, hey, I'm just gonna, she's 15. I do this with all my 15-year-olds for 5 minutes. Let me just talk to her. And that's when we talk about how can we do this differently. Maybe we can give you a pen so you can give an extra shot for that period of time. Not don't do that, but how can I help you so you don't have high sugars when you're doing that? How long can you actually take a pump up? We say safely 1 to 2 hours and no more. And then pregnancy obviously comes up and it has to be planned. Do my patients get pregnant? Absolutely. And is it always predictable who gets pregnant? Absolutely not. So it's really important to talk about contraception. I do bring it up as a doctor. I feel it's my job because I don't know that they see their primary as often. Although we have awesome primaries in our community, they're seeing us probably every 2 to 3 months. So we do discuss this with them. And then this is the cost. And I think we are almost out of time. So I will go through this part a little bit more quickly. But again, I want to leave some time for questions. It's expensive. And insulin's getting more and more expensive. Thankfully, there's more coverage. So we have worked hard as a group of endos all over the world and country to make sure that our sensors and these technologies are covered. So I'm proud to say, I think it's over 35 states are now covering sensors on their Medicaid. And the 3 main pumps we use are covered on most state Medicaids as well, which is great. But it's still a burden and it's still expensive. And so it's not covered for every single person all the time. And then family functioning. So I think it's really important to constantly talk about how they're doing. And so the visits for me, where I hear people, oh, well, we only see our team for 5 minutes. It's like, how? Because there's so much to discuss, right? And yet we don't have enough time. So I think it's important to say, okay, today we'll talk about this, and the next time we can talk about that. So we find out what the stresses are and really address them. Because they feel like this is not part of your job, but it is part of our job, is to discuss how everybody's doing with it. So we talk about how much does he do and how much do you do? And what do you think should happen? And how about we try this? And so then the teen may feel like you're more invested rather than just telling them to do something else. And then this is something interesting. Previously, you could sneak food, right? I actually have a brilliant kid that would overdose herself. She was 8. And she took an insulin pen and put it in a little cooler bag under her bed with some ice. Didn't tell anybody. No one paid attention to how many pens she had. She injected herself every single night with extra insulin and went low. And her mom would call me every night and say, I don't know why she's having these weird episodes of hypoglycemia. So we went down and down and down on her dinner insulin, her Lantus at the time. And then I finally brought her in to be admitted. And before that, I separated her and she told me, it's because her mom doesn't give her dessert. So she decided to make herself low so she could have the brownies and the cookies. I think that's a very smart girl, but the point of the matter is that it just leads to more and more of these conversations of how do we deal with this? We can't be too restrictive, we can't be too harsh, but we also have to have some rules. But now these kids are all wearing sensors and the parents are all insisting upon seeing them, so you can't hide anything. The minute you eat, it's beep, 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 right? And the minute you're with your friends, your parents are texting you. So we do make little rules or contracts to say you can't text unless it's been 30 minutes and you allow your kid to deal with it on their own. If you see it's not coming down, then you can text, and then make some sort of exchanges so that it's fair for the kid and the parent. There's no failure, just feedback. So I also tell my patients, this is not a reflection of you. This is the sugars in your body. So make it quite neutral. And they're going up and they're going down. It is not what did you do to do this? It is how are they responding and why do you think that they're responding like that? And then collaborative parenting, I think this kind of just goes in line with everything we're talking about, is spare the judgment and just talk about how can we do this together, and the parents together and the family. So we deal with a lot of families that are in 2 different homes, and step parents. And so I think it's really important so that, again, that one person is not assigned for all this care. I feel like that's just too much for a person to carry. So we make sure that we have teams involved in the care. And the number one predictor of success with diabetes is not socioeconomic status. It is not education. It's family support and support in general. So we really want everything to be positive, as corny as that sounds. I can't emphasize it enough. So if you see a child that is not doing well, just please keep in mind some of the things we talked about and all of the burdens they have to carry in that day, and hearing maybe our feedback and somebody they revere saying something negative yet again can just shut them down. So I think it's really important to be neutral and supportive as much as possible. And I think I'm out of time. I have 3 minutes, so hopefully I was okay and not taking up too much of your evening. And thank you guys for your attention, and check out the program that we have, so that you can get even more information if you would like. So thanks so much.
Awesome. Thank you so much, Dr. Swamy. That was amazing.
Okay.
I mean, I don't have anyone with type 1 in my family, but there are other other disorders that I think can factor in, in the same instance, and utilize that same input and how to handle it. So thank you.
Oh, somebody wrote, I don't see the link I was talking about. So I think I didn't send it to everyone. So what I'll do is type it here. Thank you for saying that. Okay. L. Riley at jdrf.org is Lindsay. She's the woman with whom I work to do the seminars. And again, we alternate. So just this month, we gave one to non-medical caregivers. So like parents, babysitters, delegated care aides at school would be covered in that. And then in a couple of months, we're going to do school nurses. And then a couple of months after that, we'll do another delegated care aide one. So we just switch off.
Awesome. And yes, I can certainly share the slides with everyone when the symposium is over. So I'll send those out.
Sure.
So just one question and one comment. I'll read the comment first. Dr. Swamy, I'm a psych nurse, but most importantly, I am a parent of a child with type 1, and I also have type 1 DM. I can't thank you enough for including the mental health in your care. The way that you credit the patient and parents with the stressors of managing type 1 diabetes is touching. I can't thank you enough. Your approach is helping more than you realize. Please keep on what you're doing.
Okay, Paula, I am a crier, but that really, thank you for saying that. I think it's important to recognize what you guys do every day. So thank you for doing what you do and for saying that. I'm such a sucker. Okay, let's go to the next one.
All right, next one is from Danielle. I have a student with diabetes that was just diagnosed in September. He's really struggling emotionally. His blood glucose is pretty normal at this point without too much insulin. He had to take insulin at school the other day, and it took him over an hour to take it. I've connected my diabetic students in the past to help them cope, but this student refuses to tell anyone that he has diabetes. He will not speak with anyone about it, and it seems to be isolating him more. Any advice to help him open up?
Yeah, I think this is really common. So the biggest thing that we do in clinic, actually, because they won't go to events, right? Because they're already embarrassed. They're like, I do not want to talk about this. I do not want to sit down with a whole group of people with diabetes. Is in my clinic, I just open up the doors. So if I have a kid his age, whom I usually do, because the number one age period for diagnosis is in your adolescent years, then I'll say, hey, I got to go look at your numbers for 10 minutes. But this guy over here was diagnosed like 5 years ago at your age. I'm just going to have him come in because there's so much he can tell you. I just don't know. And so I automatically try to, for our new diagnoses, foster that relationship. On virtual visits, that's been a lot harder because obviously I'm not in a room, but what I'll do is have some ambassadors in my practice who are kids that aren't perfect per se, none of us are, but really kids that have struggled and come out positively on the other end for one reason or another. They just got older, they had support finally that they didn't before, but whatever it is, they got good technology. Dr. Matt uses the term that we have imperfect tools all the time and we have imperfect things. It's not you. So I really think once these technologies have improved, we've seen so many better outcomes that finally we can tell our kids, here you are, and you're doing awesome. And this is you doing your diabetes. But anyway, I digress. So really meeting someone else like them is key, because a person who looks like them and has what they do can influence them so much more. The other thing is they have to talk to someone. So it's really critical to be part of some type of clinic or program where you have therapy involved in your visit. It cannot be, here's the name of it. I mean, if you have to, you can say, here's the name of a psychologist, please call, and have the parent do that. But it's pretty hard to get that kid to go. So if I say, hey, I'm going to step out, you're to meet this kid, and then our psychologist has to come in, it's just part of what we do, then I will tell you, like, the psychologist is so much better than I ever could be. She comes out and tells me all kinds of stuff that I didn't even realize. I think that's important. So having people in the clinic, having other kids to connect with. I think the Facebook groups for the parents. So what I've had is parents connect and they'll schedule for slightly younger kids, like a play date or a meetup. And so then they can hang out together. I think is probably the best thing. I hope that helps. And the live events. So finally, our JDR program this year, yay, is in person. So if you can get them there, like even bribery, I think is fine. Like, I'll give you $20. It's great. And they will like it. So yes.
And the diabetes training camp is in New Jersey, correct?
It's actually in Lancaster, Pennsylvania,
Oh, okay.
at the Spooky Nook. And it's a really fun facility. It looks like somewhere where you train like American Ninja Warrior races, but it's really amazing. It has every sport you could imagine and tons of courts. It's massive, and it has a hotel there. So we all stay on site, and the providers all volunteer. So essentially what the families are paying for is really to stay there and get food. So I think it's a really great program, and Matt's made it very affordable.
And it's for the full family. It's not just for the patient.
It's a kid and one parent.
Okay. So, and that's Lancaster is not far from, I mean, from Northern Delaware, it's right over the line. So, and even from Southern, it might be 2 hours. So it's a worthwhile resource for our nurses to have.
It's awesome. I would strongly, and we get people from everywhere, whether they're on pumps or sensors, like we've gotten them on it once they learn about it. But I think those types of programs are great for not saying, hey, you have diabetes, go here. It's more like, hey, you're really into this sport and I think you're really good at it. So this will teach you how to be better at it. And we don't even talk about feelings, but lo and behold, we get to talk about that because they meet 20 other people like them. And we do have circles where we chat, and these kids say the most profound things that blow me away. So I highly recommend it. It's one of my favorite things to do every year. I totally look forward to it.
Awesome.
Oh,
Well,
good. Thank you.
Thank you so much, Dr. Swamy, for joining us, and we'll hopefully partner, with your other program.
Absolutely.
Maybe for next year, we can put that on the docket. We want to make this obviously an annual event, so
Sure.
really appreciate you being here. Thank you.
Absolutely, my pleasure. Thanks, everyone. Take care.
Yeah. Nina, did you want to come back on at all?
What? Oh, you stopped me? Oh,
Yeah, you can start your video.
okay.
You're good.
Okay. I just wanted to say again, thank you. The speakers were outstanding, and the feedback we're seeing in the chats is obviously very in agreement with all of that. Excuse me. We hope you'll join us tomorrow night, 6:30 to 8:30 again. Sarah, do you want to tell us what the program is for tomorrow night to remind us?
Yes, so tomorrow night we're having Courtney Masterson from Quality Insights. She's a type 1 herself and a nurse, and she is actually speaking on mental health, so a little bit more in depth and probably giving some personal anecdotes in there. And then Tina Trout, she's going to do our pump education. We had her last year, and she was asked to come back to new technology. I think it's always important to have that.
Terrific. And I just want to extend a huge bucket of gratitude to our planning committee, Amy Hastings and Courtney from Quality. Amy Hastings is one of you guys, ladies, a school nurse. She did the pretty much the bulk of the planning here as far as recruiting the speakers, and Courtney, and then Sarah and myself. So I'm very grateful for their input and excellent collaboration for getting the speakers. We look forward to your feedback. And Sarah, will there be a survey after tonight as well as tomorrow night, correct?
Yes, so when
Okay.
you close the Zoom, hopefully it'll pop up and say fill out the survey. If it doesn't, hopefully it'll come in the email. And if it doesn't, then let me know and I'll send it out, because that's how you're going to get your CEs. So I'm sure you'll be looking for that. So thank you very much for joining us, and we'll be back here tomorrow night, 6:30.
Good night, everyone. Safe
Night.
travels if you're not at home already.